What's up? Guerrilla Radio episode 21, back with Dr. Nagel, and we brought out the big guns today with Coach Susie. She's going to help us out. So, video 3 of our 4-part series talking about low back pain. So, recapping video 1, we did a lot of mechanism of injury. We were in the clinic talking about common faults, how a spine should be looking, all that kind of stuff. Part 2, we talked about some screenings, right? Some overhead squats, some lunges, ways to look at improper movement patterns. So today is all about playing off of that. If you see, we did the overhead squat test. We'll jump in to start with that one. If we see the toes turning out, the upper back crashing, we can't keep our chest upright, what does that then mean and how do we approach that? And we were just talking before that's exhaustive. We could probably do 3 hours on just the upper body in terms of what kind of mobility could we do. So our goal is a shotgun blast approach. We're going to go bottom up. We're going to start with the foot and the ankle and come up from there. And then to get more specific on specific joints will come over time, right? So we'll try to cover that as much as we can. So let's just jump into it, right? So the first thing we led with in the last video was the overhead squat, right? So this is something you guys do in the clinic when you first have somebody come in, talk about some of the main things that we're looking at, and then how do we jump into that from a mobility angle?
So just to go through quickly, during the overhead squat, oftentimes you see a foot turn out or a knee crash.
Right.
And usually what we're looking at is limited dorsiflexion. Meaning dorsiflexion meaning being able to bend this way, right? And so if you've got limited dorsiflexion, you got to get there some way. So the body will tend to cheat by collapsing the arch and rolling forward or driving the knee in. Right?
Okay, yeah.
And sometimes even with that, it's just really limited. So 2 main areas is one's joint, one's muscle. So
okay.
Our joints and musculature. So the posterior chain musculature, like in the lower leg or calf, when that's really tight, that's obviously going to limit it. But the calcaneus and the talus, so the way the dynamic in the foot works can also happen. So a lot of people notice, we were talking about this right before we started, in the summertime, if they're really in tune with their lifting, they notice their squat, like they're challenged. But they're usually wearing flip-flops all the time.
Okay.
Flip-flops will tighten up the calf like crazy, tighten up the plantar fascia, it'll limit dorsiflexion. And when that limits dorsiflexion, a lot of times you start getting change in the dynamics in the hip itself too. Right?
So that's, and this will be the precursor for everything we're going to talk about. It's not about where the pain is. And we've talked about this before, but we could have some issues in the ankle that are stemming all the way up. So this is why this stuff is so important. It's not just as simple as saying my back hurts, how to fix my back.
Right.
We might have ankle issues that we got to deal with, right?
Yeah, and it's never I mean, there's
right.
You look at it like, what's the big rock? You take care of the big rock and start chipping away from there, right?
Okay.
And so first thing that we're going to talk about is in the ankle, we're going to talk about 2 different things, or in the lower leg. Breaking up scar tissue, adhesions, or just tension in the calf. And so when doing that, the best way to do it is not stretch, is to smash it in some way.
Okay.
Right? So we use PVC pretty frequently in the office. If you're in a gym, you can use the barbell, or if you're at home, you got dumbbells, you can use that. You can have somebody do this to you with a rolling.
So talk about the science behind this, right? We say smashing, all that kind of stuff. What are we trying to actually accomplish? What's different than stretching?
The nerd side, this is called self-myofascial release.
Okay.
Right? There's a ton of science on it. You can PubMed it, you can look it up all over the place. But whether using a foam roll or anything else, what you're trying to do is, if there is adhesions in the tissue, you're trying to break that stuff up and loosen it up. So if I have adhesions in the muscle belly, but I'm trying to stretch it, you're not going to stretch through that. You have to mobilize that. You have to break it up. So that's the same thing that you're getting with soft tissue work, right? Whether it's massage or ART or Graston or any of those things. So we're going to use Susie. Susie, hop up on here just so they can see better. And this is really, it's a matter of tolerance. You can, if you can't handle PVC pipe, you can start it on a foam roll, but a foam roll really just doesn't get deep enough.
Okay.
Right? And we brought Susie brought a scraping tool that she uses. Like scraping techniques like Graston are really, really effective for certain things, but deep, thick muscle bellies you can't get as deep into, correct?
Yep.
So you need more pressure. So doing this, like in the office, oftentimes we'll mobilize across it. So the muscle fibers run this way, right? They run lengthwise. So we're going to go across them and smash through, like that's a sweet spot for, and work our way from the back of the knee all the way to the ankle, right? like get the Achilles tendon. That's a nasty spot, but it's really, really important to get that mobilized.
And I think that's a pretty common thread around a lot of people, right? And I don't know if it's the shoes of the modern age that we live in, but there seems to be a consistent issue with a lot of people in that Achilles tendon area, and that plays into more things like plantar fasciitis, like we were talking about earlier. But
well, it is. It's shoes that we choose, and then we don't ever have to sit really very deep. So right. So I mean, you're not being forced through that range of motion unless you play certain sports.
So just to clarify, right? Plantar flexion, dorsiflexion.
Yes.
That's what we were talking about when we see if we don't have this motion, our foot kicks out to create that extra range of motion that it can't get in the ankle, and then we're going to see all sort of upstream issues. So that's what we're trying to get more of, is that dorsiflexion.
So ways to make it harder, if that doesn't bother you, you cross your leg, raise yourself up, and like I said, if you got a partner, they can start breaking it up. A barbell is substantially more aggressive, right? If you've done that before, it is substantially more aggressive to do because it's smaller surface area. So that's a quick one on the calf. This resolves a lot of different issues, but get in the habit, top to bottom. And the key is notice she's not rolling back and forth. She's picking a spot, getting into it, breaking stuff up, and then you can roll back and forth if you're trying to mobilize it out, right? Like flush it. So second thing is in the ankle, there's a couple different ways you can start mobilizing the ankle, and there's a cool tool called a Pro Stretch. If you've got lots of arch issues, I would recommend that. But we'll
cover that in a video too. We'll do a separate on plantar fasciitis.
Plantar fascia issues, stuff like that. So when you are mobilizing that, most people know how to do different runner stretches, right? Like legs straight, knee bent. But those are going to get into the calf quite a bit. If you want to get into the joint, you want to get up on the edge of your foot, like a knife edge of your foot, and then when you're mobilizing, it's a little easier if I can lean this here. So if I need to support it, so be it. But I can go use my knee as a driver, and you'll feel a very different pull through the ankle. Same thing. If I notice I got good mobility now, it's improved. If I internally rotate my foot so it's pointing in, I can mobilize and get different spots. Does that make sense?
Yeah.
So you can do it like that. I like doing them.
So that's in the joint, not the actual muscle belly of the gastroc, which you're after.
Obviously, but it's primarily going to be joint mobilization. Right?
Gotcha.
So if you've got a history of like sprained ankles and stuff like that, it's probably pretty stuck.
Okay.
If you got a history of plantar fascia issues, if you got a history of wearing flip-flops all the time, stuff like that. So a lot of that stuff will create a lot of tension in the joint as well. So and oftentimes that's stuff that may need deeper mobilization. That's why we adjust extremely.
Okay.
So
you can come through, Mickey. Don't worry about it. We are. You just get to be on camera for a minute. Okay.
So, moving on from there.
Sleeping.
So we're gonna work on the hip then, right?
Yep. So what are we looking for? We're doing the overhead squat test, and what are we looking for in that would tell us we have some tension in the hip? Or what, in some of the other exams we did, what would give us an indicator that we need to work on the hip a little bit?
So from the side, if I'm seeing somebody's folding really prematurely, right? That's one way that we're going to look at it. And obviously, if their knees are really struggle to trap out, so they're not able to externally rotate, and those are going to tell us different things. If I'm always seeing somebody initiate a squat and their knees crash forward, I know that they're extremely quadricep dominant, right? Like lower cross types of symptoms. And so that may be an activation, more of an activation issue than a tension issue. But if they're always loading like that, they're probably very, their quads are going to have quite a bit of adhesion coordination too.
I think that's a good distinction. I'm going to spend a second on cueing versus mobility, right? Sometimes you watch somebody do a squat the first time and they squat here, and you just say pick your chest up, and they find that place, right? But then other times you're saying chest up, chest up, chest up, and they're like, I am. Right, and nothing's moving. In our world, if you go to like a CrossFit level 1, they just call it an immature squat, and saying that everything else is right on, except my torso is completely forward. So you see, I think distinguishing those two things are huge, and also I think parlaying mobility versus the activation. Activation is gonna be in the next video, but mobility is awesome stuff. But I don't think I think it's supplementary to pushing people through the range of motion, right? Having somebody stand in front of a wall, which we'll cover next time, and do squatting and forcing a good position, as long as it's not excruciating for them, they go hand in hand with the mobility work. So we start here and then go next.
To get activation.
You got to create space to get activation.
There's a term called positional inhibition, meaning I can't get my body in position to get it to activate right. But at the end of the day, every joint needs co-activation, meaning if I'm a boxer and I punch something, I have to have stability on both sides of my wrist, right?
Got it.
If I activate unilaterally or in an imbalance, I'm gonna be at higher risk of wrist injury. That's every joint in the body, every movement that we do. So if I've got tension stopping me from getting there, I have to bust that up.
Gotcha.
Right?
Yeah.
I can't activate. It's positionally inhibited.
Okay.
And then when we work on activation next time, we'll talk about positional activation. How do you get people in positions where they have to fire right to move? Right?
Okay.
So it makes it a little more reflexive. So let's hit the hip though, because we're going to talk about smash first, then stretch. That's one of the rules that we always have.
Smash first, then stretch.
If you need to stretch, don't stretch and then do any type of smashing or self-myofascial work, whatever you want to call it. So smash first, then stretch. So we're going to start with this might be a little too difficult on here. You may have to go. So we're going to start with the tensor fascial ladder, TFL. You guys know the IT band. That's the tendon. So the muscle belly's here. The tendon runs down to the knee. When that is a real common contracture issue for a lot of people, especially because we sit in chairs all day. And the way we train, we run, things like that. That muscle, though, as it ties in, will create rotation in the lower leg, which creates like runner's knee.
Okay.
Right. So that's oftentimes when we see that foot turning out, knee crashing in. That's an area that we want to look at. So you're looking between the hip bone right here, and then right here is your actual hip.
Yeah.
The hip itself. Right. You can feel that. So the sharp part right here on your pelvis and here. Bust through that muscle belly, and Susie's gonna start there, and then you roll through. And after a good workout this weekend, you're probably really sore right there. So she's gonna roll through, and again, the muscle fibers are gonna run this way, so you're gonna go across them, right? And it's just hang out there, just spend some time.
Yeah.
Right. So if you get a lot of impingement feeling in the hip, that's another good indicator that you need to work on that. And then obviously, most people are familiar with just like rolling the quad, but what we tend to see is. Nobody works on this, they just beat the daylights out of the IT band.
Going lower, yeah.
And it doesn't do anything.
Okay.
Right? So it's not a bad thing to do once in a while, but doing it every single day for years is just, you're not making progress.
Okay.
So, and then you can roll through the whole hip, right? So roll through the rest of the quadriceps, you can hit, and again, there's 4 muscle bellies in the quad, but 2 of them stack. So you want to get across, right? You want to get through all the muscle bellies. Then we're gonna.
And the barbell can do well here too, right? I think sitting on your butt and smashing, because you get that weight. I think it's a lot easier to get deeper than with this.
It is, yeah, and it's really a tolerance thing.
Right. How far can you go?
It's not very. It's pretty uncomfortable.
So talk real quick, because I know it comes up a lot of time in classes that we're running about pain, right? So somebody might hit their lat or their TFL, and it's just like, whoa, it buckles outside of, hit my hamstring, it's not too bad. So what is that an indicator of, if anything?
Those are the hot spots. I mean, we're going to talk about that when we go through scapular stuff too.
Okay.
Those are the hot spots of areas that tend to get gummed up. So when you feel that, if you're on a bone and you feel pain, that's a bad thing. Right? Like if you're putting it on your hip bone and you feel like, well, it's because you're pinching your hip, or you're crushing, you're pinching on bone. If you're in the muscle belly though, and you feel tension, you feel discomfort, that's the spot to focus on. You want to roll that out and smash that out. And the thing we always say is do it every day. Don't avoid it because of pain. Do it every day because you're going to notice very quickly it gets better and easier and easier and easier. Yeah, because you're fixing the problem, right? Okay. So it's a way to future pace yourself. Like what do I expect? Well, I expect to do that every day, and I can get a little bit longer. I can get a little bit deeper. I can go a little, it gets less painful.
Okay.
So it's pain with purpose, right?
Pain with purpose.
So second thing is we're going to hit the posterior side of the hip. So this is going to be based on your overall mobility too. Some people, Susie's does yoga and everything else. She's able to get contorted pretty well. But one of the things you want to get is you want to get stretch in that muscle belly before you put tension on it. With anything, like when you do soft tissue work, we want to draw that stuff to the surface that we're trying to work on. So if you've got huge legs, it's going to be harder. So it's going to be harder to get to those areas. So if you can put stretch in the tissue before you smash it.
Which is why you see everybody, when they hit those glutes, they cross the leg.
Cross the leg, and as the further you draw your foot up, the more it's putting tension in the piriformis and the posterior.
And so the foam roller needs to be on the leg that's crossed over, because I see this all the time where people cross the leg over, then they're smashing the left side, right?
Yeah.
Kind of defeating the purpose.
And then likewise, she can roll back and forth. She can go down the glute med. Glute med's a real hot spot for most people.
Yeah.
But you can find where those areas are, and a lot of people with chronic piriformis issues,
And where's that muscle again?
Piriformis is going to run right through here. They know it because they've dealt with it for years, and it's not hard to fix. It's just primarily get it adjusted, mobilize the pelvis, work on mobility. But yeah, and the main symptom is sciatica, right? So when we were talking about, I've got back pain, you got to know what's going on, because there's a lot of different tissue there that can create problems. So this is how we'd smash it, and then let's go through just a couple different ways to stretch, right? So we talked about the front of the hip. Let's do the front of the hip first, doing like a couch stretch.
Well, you have.
Yeah. You can go, this is easiest to use with a wall. This is something you teach quite a bit as a part of the warm-up. Here's where we see the fallacies and the mistakes that create problems is, so hyperextension, so now I'm flaring up facet joints, or we see a lot of rotation, so that, which can irritate a disc or facet joint. Those are common ones. Or people try and get their foot so far back that they just end up folding and not getting there.
Yes.
Right? So so they're getting a little bit of stretch, but here's the key. This should be scalable so you don't irritate other issues, right? So if I got no flexibility, then I'm not going to be able to get my leg as vertical. That's okay. Don't fight to get your knee flat to a wall.
Right. So we could even, this is low obviously, but the idea, just inch it up from there.
And this, the bias should be, if I got low back issues, I want to keep this neutral and tight while we start working on that, right?
Yeah.
As soon as I get rotation or hyperextension, then I've lost it. I'm not,
and you won't feel it either.
What's that?
You won't feel the
When you go away from it.
Yeah, all that movement is to avoid the pain.
Yeah, exactly. You're moving away from tension to get that when you do that. So.
Yeah, and that's a good point too, because I see a lot of people do this and they just get into nasty positions because they're trying to avoid the pain. Well, the whole point is to try to get that stretch going on there, right? So trying to find some contorted position to alleviate that is defeating the purpose.
Yeah,
so scale it back a bit.
Right here, my hamstrings are super tight, right? But I can still bend my low back and stretch my low back. So again, when you're stretching, the mistake is trying to get from point A to point B, and it's really how you get there that matters, right?
So it doesn't matter what range of motion I get on this, I just need to get to the point where I'm actually making that stretch in good position.
Good position, yep. And then again, you can tweak the body positions a little bit, you can tweak your arm positions, and you can feel more quadriceps, you can feel up into the psoas. It depends on exactly what's going on with the person, but you can play with that, and you'll notice where Susie might, if she's trying to stretch her quad, might be totally vertical with it, and then I say, well, let's hit your psoas. She might have to drop it down a little bit to find that. Does that make sense?
Totally. And I've even had some of my one-on-one clients, or maybe coming off surgeries or issues, I've had them just stand and put their foot on the smallest box imaginable, and just sitting there and pushing the hip forward is huge.
It's huge, yeah.
Right? So they don't have to go, it doesn't have to look like that. We're trying to get the mechanism of that stretch.
Yep.
Right?
Let's hit stretch the piriformis in the hip. So do it this way. So you can use a tabletop if you're trying to. Go ahead and stand up for me. You can use a tabletop if your mobility is not good, or a box or anything to start to get in there and find this. And when I go here, I'm bringing my hip to the pelvis, my pelvis to my ankle, and just sitting into it. But the key is, I want the same thing. I want to keep my spine straight. So when I sit forward, I don't collapse forward. Yeah. My leg, hip, and spine should all be square with my hip, right? And I'm not sitting here like this with my pelvis open. If you don't have low back issues, it's not. You can get away with some of that stuff, right? But if you're pretty inflamed and you're trying to put out the flames, you want to limit rotation. Your hips and shoulders should follow each other. Okay. Second thing is, your foot position is going to play a big role in what you're hitting, right? So you can play with opening up your foot, bringing it down tight, and just essentially find what needs to move. Okay. And stretch. Is there anything else we can cover there?
And I think that's good. So basically, we're saying if we do this overhead squat screening and you film yourself or you send it in somewhere, like what we're looking for is if that torso is totally folding over as I try to squat, I cannot keep myself in this upright position when I squat. We have some hip tension issues, and these are some things that we could do to help alleviate some of that.
Second thing, you can go PVC pipe, foam roller, or crossballs are really good, especially when you get into these tight areas. So figure out what works best in that regard.
So how do people talk to people about going from the smashing to the static stretching, you said smash first, then stretch second.
Yeah.
That's your thing.
Mobilize, lengthen.
Mobilize, lengthen.
Right?
Okay.
And then we'll work on activate, integrate. So that essentially got the hip. We talked about the other screens we did primarily for thoracic extension.
Right.
Right?
Yeah.
Or thoracic mobility. So the reality is, like, when we take x-rays, a lot of people look, I have one I was wanting to use for this, a new patient that just came in. He's worked on thoracic extension for years. He's got a hypokyphosis, like too little curvature, way too little.
Which means we're not having that. So talked about the shape of the spine is the S. If you go back to video 1, we talked about the S in the spine.
So lordosis goes this way in the neck, kyphosis in the mid-back through the rib cage, and then lordosis. So he's a big dude with a barrel chest, so everybody has worked on in therapy trying to get him to extend. He's got half the curvature in his thoracic spine of the whole curve. And so he's got a straight spine, so now he's got all these straight spine syndrome issues, right, that we see, including low back issues. The reason he looks like he's got such a big kyphosis is that his kyphosis goes from T1 down to L3. So it's been exaggerated, but it's super, super straight.
Okay.
Does that make sense?
Yep.
So in his scenario, we actually are going to be working a lot on how do we create kyphosis? How do you start getting some flexion? I'm not opposed to him working on mobility, going into extension and flexion, but he needs a lot of flexion work, right? Because of his bias. So if it's flexion that we're trying to accomplish, that's a tougher one to create. It's a tougher one in the clinic to create, and it's a tougher one to do on your own. One of the easiest ways to do it, though, is going to...
And how would one know the difference in the screening if they did it themselves?
A lot of real straight spines are the ones that just walk right against the wall.
And just flatten it, like when we...
And you're like, all right. When you look at their posture, you'll tend to see, it's called dishing. So especially right through here, you'll see some flattening through the mid-back, right? So when we're looking at the curvature right through here. So when I look at posture, let me go from the side. I want to see the ear, the AC joint, the hip joint, and the ankle line up. And one of the things that you can visualize, but it's not always as accurate, which is why we do film, is where is this spot compared to this spot? If it's way back here, that's going to create a huge exaggeration of the thoracic curve, right? But I might be totally straight through here. If it goes this way, going this way, oftentimes you'll look very straight, but you could have more curvature, right? So in general, though, if somebody does have an anterior translated thoracic spine like this, most of the time they're going to have hypolordosis or hypokyphosis in the thoracic spine.
Okay.
Okay? The odd ones are if you see dishing through here with this.
Okay.
Is that too complicated?
Perhaps, maybe.
Okay.
But I think, let's talk about...
So we'll go through this, because at the end of the day, you need both. Our body's designed to flex and extend.
Right.
Right?
So we need it's about having mobility in there to get where we need to be.
Exactly.
Okay.
Exactly. If it's that screwed up, you probably need to go to somebody that knows how to fix it.
Right.
Bring your knee up. You're going to put your opposite hand behind your back. You're going to draw your chin down a little bit, and then squeeze and come up. And when you come up, you're trying to come up from T1, T2, all the way down.
Okay.
And it's not a sit-up. It's just pull and hold.
Okay.
Right? So we're just going to squeeze right there, and I want you to exaggerate that mid-back going into the table when you do it. Right?
Okay.
This is called a McGill curl. Stu McGill is the guy that came up with that. You alternate and just do, we teach it like it's body structure.
Okay.
20 seconds act, 10 second breaks, do 10 rounds, 5-minute mobility. And the nice thing is this is mobilization and done right, it's an activation exercise.
Okay.
Right? So we'll review that again. So the other one is thoracic extension. If we need to get thoracic extension, the easiest way most people have seen is starting with a foam roller, but foam rollers like training wheels, right?
Okay.
So if foam roller progresses to us, whether like PVC tends to hurt because if you hit bone, it pinches. So that's why there's so many cool things out there. Whether you just take lacrosse balls and tape them together, Stret's got some cool products, but there's a lot of different products out there now that hug the spine. So you get tension along the spine, and then the spine can fit right through there, right? So when we teach that, we start low, right at the lower thoracic spine. And then you're going to use your arms for leverage. So if you just go over it like this, it's not that effective, right?
Okay.
Anybody that's done this before knows what I'm talking about. You have to draw the core down, the low back down. If you need to bring a leg up, then go for it, right? So if you've got a real significant increase in your lumbar spine, the curvature. You may have to bring a leg up, but you want to push flat and then use your arms as leverage. Again, it doesn't work well on a soft surface.
Right.
You want to be on a hard surface. But just get a handful of passes and then inch up. So slide down just a little bit so you can see.
And in this, we're driving our belly button to the floor.
Belly button to the floor. So I don't like belly button to the floor because that starts screwing stuff up when we work on activation.
Okay.
I want you to think of just pushing your spine into the table.
Push your spine into the table.
Yeah.
Okay.
And or bear down like you're going to the bathroom. So when I should feel
Gotcha.
activation all the way around, which is going to tie into what we talk about next time.
Okay.
So you should be flat into the table, extend, and then extend over it.
Okay.
If you do this too much, you'll actually start creating a lot of irritation. And if you're doing this and you notice that you're not sure if you got too much curvature, too little curvature, if you notice that it's creating a lot of pain, like you're feeling kind of just unstable all the time, you might have a flat spine and you're actually putting it in range, because this is really powerful. And when you look at the thoracic spine, like the range of motion is not very significant, especially when you go joint by joint. So you can, if somebody's already halfway to end range, their neutral posture, right? Think about your finger. If this is neutral for my hand, and my neutral position for my hand is now here, I'm very quickly at end range, right? Mm-hmm. So if you notice you hit hot spots and you're feeling bottomed out is one of the slang terms we use. Yeah. You avoid that because you might be irritating it more. Okay. Right? And what you're trying to do to help yourself is mess yourself up. I think that's most everything.
I think it kind of covered the big three, right? So in a recap, we started with the screening overhead squat. Yeah. We're looking at toes curling out, knees crashing in, then we dealt with some ankle stuff, right? Yep, ankle joint stuff, foot and ankle stuff. We moved up to the hip. That's seeing the chest collapse when I try to do an overhead squat, or just even a regular squat. If I'm dropping my chest forward, I could have tight hips. We looked at anterior and posterior, digging into the hips and mobility work there. And then what we typically see, I see it a ton, and what I do is that stuck in thoracic flexion, right? And we're trying to get extension, trying to open up that overhead position. We didn't get too much into it, but the reason why I like hands overhead too, or PVC pipe sometimes, is to see what happens here when they crash. Effectively meaning if I hold a PVC pipe, I squat, and I'm rotating forward, also indicative of that upper back. So I think there's a pretty common theme that we work on with the upper back, rolling and smashing and stuff like that. And again, we're talking about shotgun blast approaches. There's nuance, and you can hear when Dr. Nail was talking about the nuance of it, and every individual is going to be specific and a little bit different, but those are some basic broad strokes.
There's one last thing. We talked about all the global stuff. I want to do one last thing on specifically getting into the low back. Okay. Right? I find that like lacrosse balls are like the easiest way to do this on your own. Is there a single ball? Yeah. There? So, Susie, I'm going to have you turn around so you can see. So when you look at everybody knows that the SI joints are like, I call them the butt dimples, right? The little dents on your back. And then if you go to the middle and then drop down, that's actually where L5 is. Okay. It's way below it. So a lot of people think that their lumbar spine ends like about where the waist is. It drops quite a bit lower, and there's a channel there on both sides, and that's where the big muscles in the low back, these paraspinals and like quadratus lumborum and the deep paraspinals, that's where they all start tying in. And I don't know if you remember in the first video I talked about how a lot of times you'll see fatty infiltration on somebody who's chronically irritating those tissues, where it's like making the tissue more ropey, fibrotic. This is an easy way to get in there, and it's a little more tolerable if you hit bone, but you can lay on your back, bring a knee to the chest, and put compressions, push your belly into the floor, and use that as a contact point to start breaking that stuff up. Okay. Right? That's really significant. If somebody's got chronic issues, then they've got probably a lot of chronic nasty tissue down there. This is an easy way to do it. And then we talked about soft tissue-wise, I think is there a scraping tool under your foot? Yeah. Techniques like Graston, if somebody knows what they're doing with that, honestly, it's not that hard to start doing scraping techniques. I've told numerous patients, get a butter knife, use the handle of a butter knife, and start working on some of this stuff. It gets a little bit harder here just because when you hit bone with a tool, it hurts like the dickens. Mm-hmm. But there's ways to do that, and if you're not, to start breaking some of the stuff up as well. You got to get deep, and then the last thing is sometimes even like a novice person, if you don't know what to do and don't have very good resources, just use some lotion, use something to lubricate the skin, and have somebody just push in those gutters and hold, right?
Yeah.
I mean, again, if you're not sure what's going on, get some advice first, because I don't want to see you flare up at something.
Hey, what's up, folks? Sorry about that. We had a little bit of a camera issue, but we were just wrapping up anyway. So thanks for watching video 3. Stay tuned for video 4 coming out next week, and subscribe to our channel so you can be updated every time we put something out. And if you got any questions specifically, put them in the comments. We can address these things one-on-one in particular instances. So thanks for watching. We'll see you next time.